I am delighted. Thank you, Teresa, and thank you to Curl for inviting me. I am so humbled and honored to be here today. And I was sharing before some of the people came into the room that I am wishing that we were all together in person. So since we are not, I'm grateful that we can do this via technology, and I'm glad that we're recording this for people who might want to be watching this later. I am broadcasting live from my home in Pilsen neighborhood in Chicago. And I'm going to introduce myself with my the slides, because I think it's a whole big story about Sandi today. So thank you for indulging me to talk about my career and what's going on. Are you able to see my slides? I'm pulling it up to slideshow. There we go. Can you see the slides? Am I seeing a couple head nods? Okay, so today I'm going to be talking about advocating for maternal health and how this has been the main focus of my career as a nurse, as a teacher, as a researcher, and as somebody who is performing service. Again, I'm Sandi Tenfelde. I am an associate professor and the director of the Women's Health Nurse Practitioner program here at Loyola University Chicago in the Marcella Niehoff School of Nursing. Oops. So I love starting my presentations for my classes with this quote by Proust that says, "A real voyage of discovery consists not of seeking new landscapes, but of seeing through new eyes." And I think that this is really great to reorient ourselves in terms of how we look at the world around us. So when I was talking with Teresa about, like, what am I supposed to do on this presentation? How do I start this conversation? And thinking about having a journey, my journey is not very linear. My journey has lots of twists and turns, and new opportunities have led me in new directions. So this is kind of like the schematic map at the beginning of the books that I love to read about where the different parts of the world are that you're living in. And I was trying to find Candyland as kind of a representation of this, but I decided to just make my own. So we're going to talk about each of these little parts along my journey, and you can see that the whole time I am juggling, teaching and research and service throughout each of these steps along the way. So I started my career as a traditional BSN nurse, four-year program with a Bachelor of Science in Nursing from the University of Michigan, Ann Arbor. Go Blue. We're a little obnoxious. I am originally from Michigan, and 5 out of 8 of my siblings went to U of M, so it was a natural career path for me to go. All 8 of us are also in the health field. So I had some really great role models in my family. We were really good at science, we were really good at the arts, we were comfortable talking with people, and healthcare was a great profession for me to lean in. I love being a nurse. I need to reiterate that over and over again. It's allowed me to do so many fantastic things with my career. And I'm a big rah-rah nurse. So anybody who is interested in talking about becoming a nurse, I am more than happy to continue these conversations. I never knew I really wanted to work in women's health. The first time that I saw a baby born at the University of Michigan, I actually passed out. I think this is kind of a funny story. I was a young student. I probably had not slept well the night before. I probably didn't have a healthy breakfast before I went into my clinical rotation. I spent the whole day laboring with this amazing couple. And right at the time when my shift was ending, she got to complete and it was time for her to push. So my emotions were high, and I asked my clinical instructor if I could stay to watch the birth, and she encouraged me. So I was there by myself, cheering on this amazing family who were welcoming their son into the world. And in the book, I knew what a baby looked like. So when the baby came out, I was very excited about that. But in the books, this is what a placenta looks like, right? It's a beautiful drawing. It looks kind of like a jellyfish. It's got some, blood vessels there, and everything is kind of, pretty and nice and clean. And in reality, this is what a placenta looks like. So the baby came out, and it was totally fine. The placenta comes out, and it is this big bloody pillow. And I, boom, pass out. I went down so hard. And this cute couple that was supposed to be concerned about their newborn was watching this student nurse, on the floor, with a vasovagal response. So let's just say it took me a little bit of a little bit of time and a little bit more research to really understand how fascinating birth is and to really get the respect of what happens in women's bodies and how the placenta is actually such a fantastic organ. So much so that when I became a labor and delivery nurse, I'm skipping ahead a little bit, but I would, I would warn the birth partners and the family members who were in the room about my experience. And then after the excitement had died down, I would tuck the placenta over to the side, and then I would invite anybody over that wanted to learn more about it. So it's really a great story, and it kind of set me on my career path. I also started becoming interested in research. I became a research assistant on a comparative study looking at certified nurse midwives compared to obstetrician care. And I sat in the basement of the University of Michigan Hospital, and I did extrapolation from the medical records to compare birth outcomes, to compare number of prenatal visits, to compare education. And so this is really important for me. It helped me to learn more about what happens in terms of prenatal care and the birth process. It helped me understand how important education is and how important documentation is, which we know in healthcare. And it also allowed me to become very knowledgeable about a field that I was interested in. So after I graduated from the University of Michigan, I moved to Chicago. And I became a labor and delivery nurse at Prentice Women's Hospital. So this is the old Prentice Women's Hospital. And one of the great things about Northwestern, and for those of you who are not from Chicago, this is a large academic medical center right downtown. It provides care for the very wealthy in our city and also for the very underprivileged. And I recognized then, I kind of knew this through my, my time in Ann Arbor when I got the social justice bug, but I really felt called to serve women who were marginalized, who didn't have as many resources, who needed that support and encouragement and education, and to really be an advocate for all women, but especially those who didn't have the resources that others did. While I was there, I also taught childbirth education classes, and that was really exciting for me. I developed a program for adolescent moms. So I would teach the classes for the private pay patients, and I also worked in an adolescent clinic, teaching young women about their bodies and how to advocate for safe and healthy birth. One of the cool things about Northwestern at the time, this was in the early 90s, and they had great benefits. They had 100% prepaid tuition to go to graduate school. So it was a no-brainer. I knew that I wanted to advance my career. I knew that I wanted to become an advanced practice nurse. Despite my love of childbirth now, I had the option to either become a nurse midwife or a nurse practitioner. And while I loved birth, I really saw my role as being more in the outpatient setting. So right after undergraduate, I graduated in May of 1993, and I started my graduate career in the fall of 1993. So I went right into graduate school, knowing that I was ambitious and knowing that I wanted to use up on this benefit while it was still available for me. So I came to Loyola. Okay, so my undergraduate was at a very large state school, and as a graduate student, I wanted a smaller program. I wanted some nurturing. Plus, I was already starting to fall in love with the idea of social justice. So this is a slide that I actually share with my students in every class that I teach. Why are you here? What's special about Loyola? What are we doing differently with your education? How can we help you transform your life and set the world on fire, right? So I have swallowed this whole Jesuit mission completely, looking at the different hungers that we have and how can we, as faculty and as students and as everybody who's affiliated with Loyola, how can we use these ideas to really make a difference in the world? So I was super excited when I got into graduate school at Loyola. It's kind of funny. So I was a labor and delivery nurse at Northwestern. I was living downtown. I was new to the city. I did not have a car. This was before the internet. So my application was a paper and pencil submission. And when I interviewed, I took the red line from downtown up to the Lakeshore campus at Damon Hall and had a great interview. And I thought, oh, this is going to be so easy. I can go to graduate school right on the lake. This is fabulous. I get accepted in the program, and when I get my schedule, all my classes are in Maywood. I'm like, where is Maywood, right? So Maywood is where our health sciences campus is. And for those of you who don't know, it's the red line to the blue line to the 308 PACE. I did have to use some of my loans for graduate school to buy a car because some of my clinicals were out in DeKalb, but I really am glad that I came to Loyola. So again, social justice is woven through everything that we do in our program. And I really think that social justice and healthcare fit together so nicely. I am somebody who is advocating for access, advocating for compassionate care, high quality, cost-effective care. All of the things that we are thinking about that will make our world better is part and parcel of what I learned at Loyola. So some of the classes that I took when I was at Loyola really helped to influence my role as a professional. There was a great course on healthcare of vulnerable populations. I learned how to volunteer at women's homeless shelters. I learned how to see health in all things and to see God in all things. I also felt like my faculty were really invested in my success and they wanted me to do well. They wanted me to change the world. And that's the type of professional I've been and the type of faculty I hope to be. I'm actually the first graduate from our program. When I started in 1993, they had a perinatal clinical nurse specialist program, but they promised me that they would have a women's health NP program. So along the way, I was able to add the coursework in order to become a women's health nurse practitioner. And I'm actually the first and proud graduate of this program. So after I in my last semester of my graduate school, I married this fabulous man. That's a picture of my husband, Eric, and I on the dance floor, which is where you would find us almost every weekend in the summer in Chicago and any other place that we can go dancing. He has been the biggest support in my life, and I'm very grateful to him. So after we got married in August, I graduated in December, and I knew that I wanted to improve my Spanish language skills. As a labor and delivery nurse at Northwestern, many of my patients were Spanish speaking only. I had 2 years of Catholic high school Spanish, so I was really good at praying, which is kind of important for women in labor, like they appreciated that, but I wasn't able to talk with women about their reproductive health choices or what was going on in their vagina. Those were not words that I learned in my Catholic school Spanish. So we were encouraged by one of my professors, Mary Kay Barron, to travel and study in Guatemala. As somebody from the Midwest who was from a big family and didn't have a lot of opportunity to travel internationally, this journey was so pivotal in my life. So Eric and I took 7 weeks. We flew down to Mexico City and we traveled on a bus from Mexico City into Guatemala, all around Guatemala. We went to 3 different language schools, living with families, studying the language, learning about the beautiful culture. For those of you who are interested in learning Spanish, Guatemala is a great place to study. They have 26 native Mayan indigenous languages. So most of the population speaks Spanish as a second language. So they are very good at teaching and understanding what it's like to learn Spanish as a second language. For those of you who are working in healthcare or working in the community, I really want to strongly advocate that you figure out how to expand your language skills. I think it's very important for us as citizens and as humans and as healthcare providers especially, to be able to attempt to provide care in the language of our populations. So it was really great for me to be able to learn Spanish. Yeah, and I'm going to talk a little bit more, but I also then was able to go back and do 3 weeks of language school in Honduras. The next year I bought a house, and then the year after that we did 7 weeks in Venezuela. But it was really this first trip that, you know, set my heart on fire about caring for Latinas in the city of Chicago. So my first job was at a community health center in the city of Chicago called Near North Health Services Corporation. I was providing primary care for low-income women who did not have health insurance. Okay, remember this is the late 90s, and so many people did not have health insurance. So this is a federally qualified health center. I did annual exams, reproductive life planning, contraception, prenatal and postpartum care, and we cared for women throughout the lifespan, including menopausal care. I was able to communicate both in English and in Spanish, which was pretty great. About 60% of my patients were Spanish speaking. And I also had something in terms of loan forgiveness through the National Health Service Corps. So for those of you who are not aware of this, this is a federal program that will forgive up to $50,000 of your student loans for a 2-year commitment. And at the time, I knew this was where I wanted to work, and I thought, okay, I can do a 2-year commitment. I loved it so much, I stayed for 5 years. And I'll talk more about Near North in just a moment, but I really love this place. So then I had a baby, okay, and I was pregnant and trying to decide what I wanted to do after my pregnancy. And I knew I wanted to go to graduate school. I knew I wanted to get my PhD. I really knew that I wanted to teach. So I sent away for applications to different graduate programs. And I knew Loyola because that's where I'd done my master's. Loyola at the time had an every other year admission program for their PhD program. And in 2002, when I sent out the application, that was not one of the years that they were accepting students. So I threw it away. I also sent out an application to the University of Illinois at Chicago, which is right down the block from me. Let's see what comes up now. Yeah, UIC. And their applications were due on February 1st. I got the application packet in the mail on February 10th. So I went, oh, okay, this is not God's plan right now. I'm gonna focus on being a mom. I'll take my maternity leave. I'll go back to my community health center. And I threw that packet away as well. And then I got a phone call from an admissions coordinator, Kate Deanna, who's a dear friend of mine now. And she said, hey, we're having a graduate open house. You know, I got a postcard in the mail and I talked with her and she said, you know, of course you should come to the open house, even if you didn't apply. And I said to my husband, I said, maybe there's still space in their doctoral program this fall. And maybe there's still money available for me. Who knows? And he said, well, maybe you can ask for a massage every week too, as long as you're dreaming. So I am a big dreamer. I wound up sitting on the couch next to this phenomenal woman, Dr. Lucy Marion. And while I was at this graduate open house, I thought that I would be talking to the maternal child people. And the director of the maternal child department had this really long line, probably all of midwifery students who wanted to talk to her about being midwives. And I was sitting there, you know, 3 months postpartum. I had my stretchy waisted pants on. I had my little breast pads. I wasn't wearing my fancy suit. But I sat next to this really sharp woman who was the head of public health, mental health, and administrative nursing. And Lucy had an R01 funded study looking at reducing the risk of sexually transmitted infections in African-American women on the west side of Chicago. And I said, oh, fancy that. That's what I do in Cabrini Green at my community health center. And Lucy needed a clinician on her study. So she invited me into her program. I was able to see patients clinically and do the research that was needed for her study. And because I was faculty, or because I was considered staff, the PhD program was, I didn't have to pay out of pocket for the tuition, which was pretty fantastic. So I got my PhD in nursing from the University of Illinois at Chicago from 2002 until 2009. Now you'll notice that it took me 7 years to get my PhD as a postmaster's student. I had 3 babies along the way. So June was born in 2002, Cole was born in 2005, and Sage was born in 2008. So again, here is this wonderful juggling act of trying to move on with things that are happening in your life, be fully present as a partner and as a parent, and pursue my love of learning. But really, I just wanted that darn hat. Like, that is a really cool hat. So, so this was just, I was pregnant or breastfeeding the entire time I was in the PhD program. And we are just so resilient. And if you have support and encouragement from the people that are around you, and you're blessed with a healthy family, there's just, you know, you can get stuff done. So while I was in my doctoral program, again, I was working on Lucy Marion's R01 study. When that completed, I started teaching in their midwifery and women's health program. And I really missed clinical practice, you know? So after Lucy's study ended, I wasn't seeing patients anymore. I was focused on my studies. I was focused on my research. I was trying to figure out what I was doing with my dissertation, but I really missed seeing patients. And as a nurse, and especially as a nurse practitioner, that's really what feeds my soul. So while I was in this program, the current director of the program, who is Dr. Barbara Commune, she is a nurse midwife, and her area of research had been on shoulder dystocia and pelvic floor dysfunction. So there was a team of colorectal surgeons from UIC who saw pelvic floor dysfunction on her CV and said, hey, we would love you to work in our clinic. We want an advanced practice nurse to work in colorectal health. And Barb, bless her heart, said, you know, if I'm going to practice clinically, I want to catch babies. However, this would be a great job for a women's health nurse practitioner, and I've got a great one whose name is Sandi Tenfelde. So Barb came to me and said, Sandi, do you want to work in colorectal health? And I said, no. So I had no interest in working in colorectal health. But she said, you know what? It might be a great opportunity for you to practice clinically. You know, And I realized that I am not intimidated by people with their pants down. I was already very familiar with pelvic floor. I was able to look at patients holistically. I worked with a great team of surgeons. I was doing a lot of the management of patients so that they could self-manage their chronic healthcare conditions related to pelvic floor. And they also had a lot of industry-sponsored randomized control trials. So I became the research coordinator for our team, which was pretty fantastic. So I got exposed to a lot of ideas about research and was able to be included on some really great studies. And then it really helped to set my stage for more decisions that I've made in my life related to my research career. While I was in the PhD program, I also had a pre-doctoral fellowship. I feel very fortunate about this. It was from the Chicago Center for Excellence in Health Promotion Economics. So healthcare economics is super important, and as clinicians, we need to be really aware of this. I've posted this picture here, which is looking at the quadruple aim. So it's as a reminder for all of us in healthcare, how we want to really be looking at outcomes, but we can't just look at outcomes. We need to look at the patient experience. We need to look at the provider experiences, and we also have to be mindful of costs. And superseding all of this is equity, so we want to make sure that that is part of the picture. I think that there's lots of adjustment that's happening in terms of how we're looking at public health and where everything fits. We went from the triple aim, now we're thinking about what parts go into the quadruple aim. But it really helped me to keep these ideas in focus as I've moved through my career as an educator, as a clinician, and as a researcher. Funnily, this was at the University of Chicago. I was in graduate school at UIC. There's really no good public transportation to go from the Tri-Taylor area down to Hyde Park. So all of the money that I got from my pre-doctoral fellowship, which was not that much, was spent in taxis back and forth. But it was really good. I'm glad I did it. Okay, so one of the challenges with me is that I have so many things that I'm interested in, so many things that I don't know, so many things that I want to study, so many problems that are out here in our healthcare world, that I had a ton of different questions that I wanted to look at. And this is really challenging for a doctoral student. It's really challenging for anybody who's thinking in terms of a scientist. And I realized that I am a scientist. I think like a scientist. Even though I wanted to get my PhD so that I could teach, I really am a scientist. I look at the world and say, why are we doing it this way? What do we need to know to do it better, right? So my biggest charm and my biggest challenge is that I have too many ideas. And this is really frustrating. However, when you're in graduate school, and I remind my students all the time, this is not your life's work, okay? This is teaching you a lot of really good skills to ask good questions, to do the necessary literature reviews and research so that you can understand what's been done, where the questions are, what you might decide to consider as an intervention, and to scientifically test it. So it's really important for me to reiterate that it's okay to have lots of good ideas or lots of bad ideas or lots of crazy ideas, because the world is big and we have so much work to do. So I decided to do a secondary data analysis of data from my clinic. Remember, I had been working at the FQHC in the inner city with low-income women. I knew that doing a secondary data analysis was going to be helpful. There are benefits to doing secondary data. It's cost saving. It's a lot easier than trying to recruit patients into a study. And you can have a very big sample size, which is really wonderful. The big sample size increases your statistical power and allows you more generalizability of your findings beyond your individual study. However, there are limitations to secondary data analysis. So my data was not collected for research purposes. Clinical level data can be really messy, okay? So, and I'll go on with more stories about that later. But I wasn't involved in the selection of the variables. I had to use what was available to me. I wasn't included in the data collection, although some of the patients that I included in the study were women that I had seen in my care. So I looked at the predictors of breastfeeding exclusivity and duration in low-income women that go to WIC. Okay, so WIC, for those of you who don't know, is Women, Infants, and Children. It is a federal program that supports women through pregnancy and through their postpartum. Women during pregnancy get coupons for food and nutritional information. After they deliver their baby, if they breastfeed, they continue to get coupons for food. If they decide to give formula, then the baby is on WIC and can get formula through WIC. So this picture here kind of makes me gag a little because this is what medical records used to look like. So we would have paper charts. So this is before the electronic health record. This is how I spent my dissertation time. I was given a list. I combined data from the state of Illinois' WIC department. So I got a list of all of the women at my health center who initiated breastfeeding. So in order to be in my study, they had to initiate breastfeeding. And then I was looking at both the mom's chart and the baby's chart to see the predictor variables. So if I could understand who were the moms who were likely to exclusively breastfeed and who were the moms who were likely to breastfeed for longer durations. And often in my patient population, this would mean some complicated research for finding the matching pairs. We would often have a mother whose last name was Hernandez and the baby's name was Rodriguez, and I would have to match them. So this was a big bunch of work. Again, secondary data analysis can be really amazing, but it also can be really challenging. Okay, so the picture on the center of the screen is Dean Lorna Finnegan. For those of you who don't know her, she is our new dean in the School of Nursing at Loyola. And I met Lorna when we were both PhD students at UIC. She was working on Lucy Marion's Well Woman study, as was I, and she became such a great mentor for me. She became my dissertation advisor. I will say that she put me through my paces, and it was very challenging, but she is such a hard worker and she is so smart and really helped me with dissemination of my research. So she helped me make my dissertation so tight and so readable, and there was no room to, or there was very little room for argument with our scientific writing. So she taught me a lot, and I was able to get 3 papers off of this study, which is pretty fantastic for dissertation research. Like a lot of people, are, aren't able to complete a dissertation, and then for those of us who do, to be able to get 3 papers off of it, that was pretty big stuff. So my first paper looked at the predictors of breastfeeding exclusivity in a WIC sample. That's a picture of my daughter, June. So I want to kind of keep grounded in the fact that I was pregnant or breastfeeding this entire time that I was doing my research. In my study, my women in my community health center, only 23% of these women breastfed exclusively. And exclusivity means that they are not giving formula, okay? So I looked at the women who were breastfeeding exclusively and tried to understand who were they? How were they different from the women who supplemented with formula? So the women who were most likely to breastfeed exclusively in my study were those who received prenatal care in the first trimester. There was an insightful tool that we used in our clinic that asked women how they were planning on feeding their baby. And for those women who said that they were planning on breastfeeding only, they were more likely to breastfeed than women who said that they were planning on giving breast or bottle. And then women who were overweight or obese were less likely to breastfeed than those women who were normal weight or overweight. So one of the tricks with secondary data analysis is I don't have a lot of understanding of the whys behind it. I can only tell what the statistics point us to, but there are speculations, and this paper is available through PubMed if you want to read it or if we want to talk more about it, but I'm not going to go into great detail here. I'm going to talk about the other parts of this dissertation also. So my second study, that's a picture of my son, Cole, predictors of breastfeeding duration in a WIC sample. And in this study, I looked at survival analysis. So survival analysis is modeling change over time. And this is something, another statistical technique that I had to teach myself. I did have a statistician on my committee. Thank you, Dr. Campbell. It was really a lot of work for me to be able to do this. So looking at women over time and trying to understand who stopped and when they stopped. So the rates of breastfeeding duration in my sample were also low. At 6 months, only 31% of my sample were breastfeeding, and at 12 months, only 6% of the sample were breastfeeding. Women who were most likely to breastfeed for longer durations were usually the older moms. They were of Mexican ethnicity. They had previous breastfeeding experience, and they had breastfeeding support from family or friends. My third paper from the dissertation is a picture of Sage, my youngest, and Cole's, photobombing on this picture. But my third paper out of this looked at why women stopped breastfeeding. And one of the interesting things with WIC is when women stop breastfeeding, they need to tell the WIC counselors, why are you stopping? And the majority of women reported stopping because of a perception of insufficient milk. So women just didn't feel like they were making enough milk to continue feeding their babies. The average length of breastfeeding in my study, again, was only 16 weeks. And the reasons that women stopped breastfeeding included the perception of insufficient milk. Many women reported returning to work or school or having some problems, related to breastfeeding, that they didn't have enough support to continue nursing. The main times when women were stopping were at 5 weeks and also at 13 weeks. And again, because this is secondary data, I don't have a lot of insight into why exactly what was going on there, but we can guess that 6 weeks is often the time when many women are returning to work. We need to look at the policies that are in place in terms of our workforce to be able to support women who are returning to work after childbearing and want to be able to pump and continue nursing. Also at 13 weeks was a time when many women stopped. That's often a time when people start supplementing with formula or cereal, and we've got to do more work. So one of the greatest things I thought about doing this research was that I was able to take all of this information back to my community health center, right? I was able to go back and say, here is what I've learned from looking at our data, from understanding the big picture about what's going on. How can we tailor our interventions to these moms who may not have the support that they need, who we might be able to recognize if they are younger, if they are Black, if they don't have any breastfeeding experience, if they don't have a lot of support. How can we help them? How can we channel our energies to this patient population? So that was really nice of me to be able to see this come full circle and to be able to give back to the community health center. Okay, so after I finished at UIC, I was hired at Loyola, which is pretty fantastic to come full circle and to come home. I was hired in 2009. I became the director of the Women's Health Nurse Practitioner program in 2010, which just completely surprises me all the time. Like, I'm the first graduate from the program and now they're letting me lead it? Really? This is pretty incredible. So I'm very, very proud of that. I've also done some great work with the Gannon Center. I was a Gannon Scholar in 2015. That allowed me some fabulous time to focus on my research so that I could become an associate professor with tenure in 2016. So what a big bunch of work. I'm so happy to be tenured. Loyola gets to keep me forever, which is great, because this is really my home. So again, I wanted to get my PhD so that I can teach. I love teaching. I've taught both at the undergraduate, at the graduate level, and now I'm teaching at the doctoral level. So I focus mostly on the women's health content for undergraduate and graduate students. And I've also recently, I've been teaching 2 new classes this semester. So this is a big bunch of new work for me. Due to COVID, many of my graduate nursing students who would be in clinical practicums have had challenges with placements because of COVID. Many practices do not want to have students in there. So we are still looking at innovative ways of trying to get the education for our students that they need. So I've created and developed a simulation course where we're using a product called iHuman that has some simulation cases in it. And we're able to, it's really been fantastic for me to be able to see their progress and learning through simulation and the debriefs that we do each week. I'm also now teaching the doctoral course on population health, which I think is pretty fantastic to see these students come in with the ideas of how we can use data and how we can look at the big picture in order to devise clinical effectiveness trials and quality improvement studies at the doctoral level to improve patient care and health outcomes. So here I am. I'm a women's health researcher. I'm starting my career at Loyola. I'm trying to figure out what I'm doing, and I'm still trying to figure out what I'm doing. When I interviewed for my position at Loyola, I had the good fortune, Dr. Nancy Hogan saw my name, or saw pelvic floor on my CV, and she said, hey, you know what? We have a great pelvic floor team at Loyola. So this picture is of Dr. Linda Brubaker. She's a female pelvic medicine and reconstructive surgeon. The title of their group used to be urogynecology. So if you're a little confused of what she is, she's a pelvic floor expert for women's health. She was the Associate Dean of Research for the School of Medicine. She eventually became the Dean of the School of Medicine, which is pretty fantastic. And she was a research mentor of mine. So when I spoke with her on the phone while I was interviewing, she said, Sandy, what do you want to do? And I said, well, I want to teach. And now I'm being groomed as a researcher, but I really love clinical practice. And in all honesty, in nursing, we don't have a good model for this in academia. We don't have a lot of clinicians who are researchers and are educators. And Linda Brubaker said, you know what? I feel very blessed that I'm able to do all three. Loyola is a great place where you can do this. So once I heard those words and I knew that there was, a team that I could work with, I thought this was going to be a great step for me. So I started my career at Loyola working on pelvic floor health. And I had some great mentors along the way. Dr. Kim Kenton, Dr. Lena Hatchett, Dr. Sue Penkoffer were really angels in the beginning, helping me to launch my career, trying to understand what I wanted to do. I was trying to practice clinically with the team in female pelvic medicine, and it's a great role for a women's health nurse practitioner. There are many WHNPs who are working in pelvic floor health, but I was just having a challenge. I couldn't figure out how to fit in with them. They understood what my PhD was as a researcher, and they were able to include me on some studies, and I had a couple studies on my own. But as a clinician, they had never worked with a women's health NP before. So I kept trying. I kept trying to figure out what I needed to do. And a lot of their research was focused on being a surgeon. So I am not a surgeon. I was looking at ways for women to sorry, I'm blanking right now, to self-monitor or to control their own health problems through self-care. So I became a yoga teacher. And there's a kind of a funny story behind this. After I finished my PhD, I said to my husband, Eric, I said, you can go back to school now. If you want to finish your master's, he was a few classes short in computer science. And I said, if you want to finish your master's and go back to school, you can. And he said, well, I don't want to go get my master's. We were really getting into yoga as a couple. And he said, I want to be a yoga teacher. And I said, really? And he went to this great program where it was 14 months long and he had to write a thesis. And I said, oh, you should write a thesis on yoga for the pelvic floor. And he said, I don't want to do pelvic floor yoga. You do pelvic floor yoga. So in my heart, I always knew that I could go back and learn more about yoga. So there's a lot of evidence to suggest that the muscles that we're using in our yoga practices can influence our pelvic floor. But also I started looking through the lens of psychoneuroimmunology. And these pictures of Dr. Karen Sabin and Dr. Linda Janusek, Dr. Herb Matthews, it's really the team at Loyola that helped me to connect these ideas and looking at how the mind and the body are connected. So we know that there's evidence in other patient populations that yoga and mindfulness can help to reduce inflammation in the body. And I did a study looking at women who had urgency urinary incontinence and how yoga can help reduce inflammation and might make their symptom burdens better. I also did a study again with Dr. Lena Hatchett, shout out to Lena, and with Karen Sabin, a qualitative study looking at yoga and mindfulness for Black women. Because we often see them as underrepresented within the yoga population, and wanted to see what their beliefs and ideas were. So that was pretty exciting. So I'm still not practicing clinically with the pelvic floor team. I'm not practicing clinically, and it's driving me crazy. The pelvic floor team had a multidisciplinary pelvic health clinic. And I thought, oh my gosh, so here I am, a women's health nurse practitioner. I know about the women's parts. I know about the colorectal piece. I know about yoga. I think I would be great in here. I also wanted to talk with patients about their sexual health. And I asked one of the clinicians, who's talking to your patients about sex? And she said, I'm a surgeon. I don't talk about sex. And I said, well, let me do this. And she said, Sandy, just because you like sex doesn't mean you can talk about it. You need more education. And I went, oh, okay. So I am happy to go back to school to get more education. I went back to Michigan in Ann Arbor, go blue again, to become a sexual health counselor. So it was a program through the School of Social Work. They have a sex therapy program, they have a sexual education program, and they have a sexual counseling program. Sexual counseling is the healthcare piece. So I was very fortunate again to start incorporating these ideas about sexual health and women's health and postpartum care. So I worked with Colleen Fitzgerald on a research study looking at postpartum sexual health in women who have pelvic girdle pain. The picture next to Colleen is of my colleague, Jeff Alba. So after I finished as a sexual health counselor, I still wasn't able to practice clinically at Loyola, kind of driving me crazy now. But I wanted to practice clinically. So I called Jeff. Jeff is a sexual counselor. And he started up a program at North Shore in the Department of Urology. And I said, Jeff, who is working in women's health with sexual health? And he said, Sandy, we don't have anybody. We need you. Will you come? So I'm going to talk a little bit more about my role as a clinician in the sexual health program up at North Shore, but Jeff is a fantastic researcher, and I was able to get some really good research experience working on his team. So as my journey continues, now I am looking at maternal health and postpartum care. The picture on the final slide up at the top is my colleague, Dr. Lindsay Garfield, who's my partner in crime right now. And then at the bottom is a picture of Dr. Arden Handler. I have a research mentorship right now. She is from the University of Illinois at Chicago. She's an epidemiologist in maternal and child health, and she's one of the leading experts in the nation. And she's really good with big data. So for the next year, this is who I am partnered with so that I can figure out how to make sense of my amazing journey in women's health, but now with a focus on maternal health and postpartum care. So practicing clinically at the sexual health program, this was a urology clinic. And the idea when they brought me on was that I would help to increase their female patient population. There are many women that are struggling with sexual health issues, and especially when they have a pelvic floor condition, this seemed like a natural fit to bring me into the urology center. However, while I was there, they also care for a large percentage of male patients who have prostate cancer. And we were very fortunate. Men who have prostate cancer, they struggle. They have urinary incontinence, they have erectile dysfunction after their treatment, and any cancer diagnosis is affecting many parts of their life, including their sexual health. As a women's health nurse practitioner, I can see men for both their reproductive and sexual health needs as well. So if you're like, wait a minute, she's a WHNP, how is she seeing men? Yeah, it's part of our role, okay? So again, not intimidated by people with their pants down and talking about sexual health as an inclusive part of your whole health. However, I worked there for 2 years and it was pretty fantastic. I learned a lot from Jeff. I loved my patients, but we had that little election in 2016 and I realized that I was helping old white rich men get erections. And while I was very good at it, that's not really where I'm called to serve. So I had a little existential crisis about what I was doing with my life and where I wanted my career to go. And I unfortunately, well, I made the decision that working at this clinic was no longer what was serving me in what I wanted to do with my life. So I came back to Near North. I begged my medical director, who was somebody, Dr. Tim Long, who I worked with back in the 90s. He was still there. And I said, please, can I come work, please? And he said, Sandy, we want somebody who's full time. And I said, I am not giving up my gig at Loyola, okay? So I'm really happy as an associate professor. I'm really happy doing the teaching and research, but I miss patient care and I want to be there 1 day a week. I miss women's health. I miss reproductive rights and social justice and community health. And I'm so grateful that they allowed me to come back. I see patients every Thursday. I was there yesterday from 8 a.m. until 6 p.m. I saw 25 women. We put our roller skates on. It is a whole bunch of work, but it is pretty fantastic. And I'm so glad that I'm able to do that. So really, patient care feeds my soul, I have to tell you. And once I was back in the community, I realized how important this was for me as both a professional and as a researcher and as a teacher. So here is what I teach my students, right? And this is what I do. This might be a patient that I see in my clinic, okay? And just by looking at her, I can tell a couple things, right? She's carrying more weight than she should be for her height, and she's also smoking. So as a clinician, if I just tell her, you should lose weight, you should quit smoking, right? I feel like I've done my job, right? I've addressed some health issues. However, we really need to look at a bigger picture here through the lens of community and population health. So if we understand that her whole family has a problem with obesity, they may not have the information and education in order to provide healthy meals. And this may be a hereditary component to her body weight as well. Also, we might understand a little bit more that she hasn't been connected to healthcare since she was a child. She got her annual exams or her immunizations in order to go to school, but then she's been very disconnected from healthcare since then. So she may not have had those opportunities through annual exams to get the positive reinforcement on making healthy lifestyle choices. We also might realize that there are very few healthy choices that she can have in her neighborhood, and she may actually be living in a food desert. It's a lot easier for our patients that live in underserved communities to survive on Flaming Hots and Monster energy drinks than it is for them to have adequate nutrition with fresh fruits and vegetables. Also, with smoking, she may have been exposed to smoke ever since she was a child. Even if she quit smoking, she may still have the influences around her that make it more challenging to stop or may continue to influence her health. She may live in an underserved area. I live in Pilsen. We had coal-fired power plants, right? So the particulate matter that can influence what's going on with her lungs and predispose her to problems. She also may live in substandard housing that has lots of infestations, and we know that cockroaches and dander can be triggers for lung conditions. We also know that target companies or tobacco companies target teens, right? So we have to look through the lens of what else is going on in society that make it so challenging for us to fight these problems that are against the health. And also, if I tell her to go outside and exercise, what are the resources in her community, right? Does she have a safe place to go out and walk? Does she have a safe place with equipment that works to be able to go play? So if I just sit there and chastise my patient about the things that I think are important, I'm really missing the bigger picture. So as an educator at Loyola, as somebody who's a member of the community, I really want us to start thinking bigger, broader pictures. And I'm glad that Curl is, encouraging students to do this as well. So I think that this is a nice kind of pictorial. I'm a very visual learner, as you can tell by my slides. I like lots of pictures and colors. But if we look across the horizon at health, we can see that the earliest place that we can do any interventions is really when people are healthy, right? So we want to start and change the paradigm of what we believe in for health for people in our nation. We really want to start working earlier in our approach to changing the healthcare. People start to develop risk factors. We don't really know when this tipping point is, but at some point they have a detectable pathophysiologic abnormality. That's when we start screening, right? So that's when we start saying, oh, your pap smear is abnormal, or oh, your blood pressure is starting to creep up, before they have symptoms, before they have problems, before they die, okay? So what we should be looking at are these social determinants of health. Our current model, again, is after people are already over the cliff, we're working with primary prevention and early screening and early detection. We're looking at safety net programs and secondary prevention. And then we're looking at, intense medical care and tertiary prevention. But really, the place that we will have the most return on our investment is if we start looking at these social determinants of health. Some of the work that I've been interested in lately is the Adverse Childhood Experiences program. Okay, so there was a study that was done, and they said, listen, all of the stuff that happens to us in our lives make us who we are, both the good and the bad. And when there are many things that happen that are bad, these adverse childhood experiences, it predisposes us to poor health outcomes. Okay, so again, if I just sit and look at this woman now who's overweight and smoking, I may not understand what came before. What were the predisposing factors that led her to where she's at? The early work that was done on the ACEs study, especially with women, lets us know that the more, there's a dose response effect. So the more bad things that happen, okay, so physical abuse or neglect, sexual assault, watching dysfunction in the household, watching violence in the streets, all of these things predispose us, okay? And the more that we see, the more that we're exposed to, the more inflammatory markers we have in our bodies, and the more poor health outcomes we can have. So as healthcare professionals, it's really important for us to take a step back and recognize that, try as hard as I might right now, we're working against a lot of things that have come beforehand that we might not understand, and we haven't been asking the right questions. Women who have been exposed to more adverse childhood experiences have more substance abuse, they have more unintended pregnancy, they often have more sexually transmitted infections, they start having intercourse more earlier in their lives. I'm not an English major. They have more exposure to intimate partner violence and sexual violence. So it helps us to understand that we've got a lot of work to do, right? We want everybody to be safe and healthy, and we need to start looking at the antecedents of what happens before they come into care with us. So 35% of women reported some kind of physical or intimate partner violence. In the study that I'm citing, girls between, and not just girls, I'm focusing on women's health right now, but I don't want to only look through this lens. And I also am mindful that, I'm often using very binary pronouns and categories for sexual health. So forgive me on that. I'm trying to get better. And now that I'm saying this out loud, I'm like, yeah, I should go back and change these slides. But looking through the lens of the idea that people are abused, that sexual assault is a thing, that we need to talk about it. And there are long-term negative outcomes, both on our physical health and on our mental health. And I just thought that this quote that says trauma is a root cause for our most pressing physical health, mental health, and social problems, we really need to be mindful of this. So we really want to create a safe environment. We want to build these relationships and connectedness, and we want to support teaching and emotional regulation. These are all the things that we can do to help with trauma-informed care. There's a group that's in Chicago that's called THEN, which is Trauma, Health Equity, and Neurobiology. There's some really fantastic clinicians and researchers who are doing some great work at trying to make the connections about how our experiences and trauma and how adverse experiences like racism and sexism and poverty really influence our brain and change our neurobiology. This led me to a great study, and it's how Curl and I found each other. I was, thinking about what my next steps are, what am I interested in, how can I work? There was a grant for health equity through Loyola, where they encourage academics to partner across different institutions. And I noticed that Curl was working with this fantastic organization called Housing Opportunities for Women. And they were mostly working with women of childbearing age who are chronically homeless. And I thought, oh my gosh, this is my patient population. Like, I need to figure out who these people are and what they're doing and how I can help. How can I be on the team? So with Christy Mason from social work, with Christine George, who's in our audience today, and with Christine Haley from the Housing Opportunities for Women, we put together a fabulous grant called Partnering with Homeless, hold on, I've got to move my thing over here. Partnering with Homeless Opportunities for Women, or Housing Opportunities for Women, to develop an interprofessional learning and service experience to reduce health disparities for homeless women. So we were talking about how to talk about trauma-informed care for the workers on the front line, for the clients that they were serving. We were going to expand this to include all of the students through Curl and the School of Nursing. It was a great grant, but unfortunately, like many great grants, this one was not chosen for funding. So, we are going to try and resubmit this again. Unfortunately, trauma has not gone away, and homelessness has not gone away, and the needs of women with childbearing ages have not gone away. So there's another opportunity for us to polish this up and get it out again. But I'm really grateful for the team here who's been working with us. So let's look at what's going on in Illinois, right? So I'm looking through the lens of population health, like where are we, what are we doing? We're getting a little bit better on many of our health outcomes. This is data from AHRQ. And I'm going to dig a little bit deeper into what's going on with maternal health. So one of the markers of the health of a nation is really looking at their infant mortality. And you can see infant mortality is measured as deaths per 1,000 live births. And as I've broken this out in terms of race and ethnicity, you can see a stark disparity for African Americans who have almost triple the rate of infant mortality. So I'm a very visual learner. Again, I think it's all, it's nice to see it in a graph representation also, that you can just see that there's a big difference going on here. What's going on, what's happening. In 2018, a really big report came out looking at Illinois maternal mortality and morbidity. And this is set me in a new direction of what I'm doing on the front lines as a clinician and what I can start learning as a researcher. I'm not going to go into a lot of detail on this slide, except to say that non-Hispanic Black women are 6 times more likely to die of a pregnancy-related condition than non-Hispanic white women. 6 times in Illinois, right here, right now. This is so much work needs to be done. And it's not just the poor and impoverished, okay? So I like to reorient people that, Serena Williams, when she was delivering her baby, had a clotting disorder and was throwing a pulmonary embolism and almost died. She had to advocate for herself over and over again to say, listen to me, please listen to me. Beyonce, I think this picture is just fantastic. I don't know anybody that looks as good as Beyonce after they have a baby with twins. But Beyonce had pregnancy-induced hypertension, okay? So here are 2 very powerful, highly resourced, educated women who had to advocate for themselves, and we almost lost them, okay? So non-Hispanic Black women are 6 times more likely to die. So my patients, they're not Beyonce, they're not Serena, but we need to make sure that we're advocating for these women, and we need to look at these factors more closely. So when are they dying? We've expanded the idea of when women are dying. Some women die during pregnancy. Some women die at birth of their, while they're in childbirth. But if we look at, what's happening after they deliver the baby, the 56% of our women are dying in that first year after birth. And this is just unacceptable. This is unacceptable. When they look at these factors of what's causing these deaths, many of them are preventable. So if we look at cardiovascular disease, if we look at infection, if we look at bleeding, if we look at heart problems, if we look at stroke, there are so many things that are happening that we can intervene with and we can recognize and we can prevent. So the recommendations from this 2018 article really say that we've got to look at how we're covering maternity care, right? So right now, many of our patients are on Medicaid or through the Affordable Care Act having insurance. And we really want to expand that for women, not just in those first 90 days after a delivery, but through that first year post-birth. I put up some initiatives from the American College of Obstetricians and Gynecologists because I think that this helps to keep us grounded in terms of what the leading experts are saying. How do we look at changing the hospital systems and culture? How do we look at optimizing postpartum care? This is really what my driver is right now, looking at levels of maternity care and improving access, and also trying to collect better data. So we need a political will and commitment. Please vote, okay? So find the issues that are important for you, whatever those are. I often say, like, I don't care how you vote, I just want you to vote, but I do kind of care how you vote. If this is important to you, then make your voice heard. I am a strong believer that we need high quality, cost-effective care, including contraception and safe abortion. Even those of us who are pro-choice want abortion to be safe and legal and rare. We need stronger health systems. We need better prepared clinicians who have innovative ideas. We need a healthcare system that's responsive to the needs of the individuals that we're caring for, not just to the bottom line of the clinic that's running the programs. We need improved access to quality care before, during, and after childbirth, and we need accountability. We need better data. We want to look through the bigger lens of health and well-being, and we want this to go to everyone and everywhere. So there was a great article that was out in 2016 that looked at quality maternal health care. We really want to prioritize quality maternal health services that respond to what's local of the need and the emerging challenges within that patient population. I love this picture. I think that for those of you who haven't seen the idea of equity, so if we do equal, which is on the left-hand side, and everybody gets the same box, those who have greater needs are not going to be able to get the response that they want. If we disperse the boxes in the way that allows everybody to be able to have a good outcome, it makes more sense. That's what equity is. Ideally, we want to reduce or remove any barriers at all, okay? So promoting equity through universal coverage, right? Of quality maternal health services, including to our most vulnerable patients. We also want to increase resilience and strengthen the healthcare systems by optimizing the health workforce. Okay, so as somebody who is educating the next generation of providers for women's health, this is where I feel is really important. We want to talk about what the issues are. We want to make sure that there are resources for our students and our future leaders in healthcare to be able to make changes. We also want to look at cost. Okay, so again, my healthcare economics piece comes back to me. We want to guarantee that the things that we do are sustainable. We want to look at financing for maternal and perinatal health. And then finally, we want to accelerate this process through evidence-based initiatives and through advocacy and through accountability. Okay, so what am I working on now? This is exciting. This is with Lindsay Garfield and Dina Tell. Hi, Dina, I think I saw you on this. And Lisa Masseter, who is the director at Chicago Alliance. As a clinician in my community health center, we use an electronic health record called Centricity. All of the electronic health records share this EHR, and I applied for a grant with this team to have access to looking at the predictors of postpartum care attendance in low-income women that go to the FQHC. So currently we have 58,000 pregnancies over, we follow them through the prenatal period through 1 year post-birth. So any woman who had a pregnancy at least through 23 weeks, which is the time of viability. What we're trying to understand is some of these women have no postpartum care. How are they different from the women who do have postpartum care, okay? So when do these women come back in? Are they here before 21 days? Are they here around their 6-week visit? Do they come back at 12 weeks? Are they coming back? And we're looking at a logistic regression. So if we think of postpartum care attendance as either a yes or a no variable, that's a dichotomous outcome. So we can look at a logistic regression. We can look at these individual predictors in a bivariate correlation and then put them into a logistic regression to figure out what the best model is. The predictors that we're currently working with, we have a ton of data, like a ton of data. But if we limit these to the ones that are identifiable in the prenatal period, we've got age, race, ethnicity, marital status, employment, how many times has she been pregnant, how many births has she had. One of the things that I wanted to include is looking at the distance from a healthcare center. We know that many of my patients, have to travel across town to get their care, and that can be very challenging. So while I don't have identifiable data like an address, I do have a zip code. So that's considered non-identifiable data. And I can tell if the zip code where the individual resides is in the same zip code as where they get their care. So I'm using that as a proxy measure for distance. I can also know when they started their prenatal care, which gestational age they came in for prenatal care. I can look at how many prenatal visits they've had. I can look at their gestational age when they delivered and how they delivered, if they had a vaginal delivery or cesarean. Does that influence if they come back in for postpartum care and when they come back in? So that's currently what we're working on. It's a big bunch of work, and I'm super excited to be doing that. Here is a model looking at how these primary determinants of health behavior influence their health behavior, influence the health outcomes, and influence their utilization. So this is the Anderson model of health behavior utilization. And I'm also working on the Chicago Collaborative for Maternal Health. This is through Alliance Chicago. Again, this is our big repository of data, and it's a consortium of community health centers across the city. We're working on a quality improvement project to improve maternal health, and by developing a registry of medically complex patients. Right now in our health centers, we are trying the best that we can, but it is often a very broken and fragmented system. Women who are seen in the prenatal period, if they have medically complex issues, we care for them in the clinic. We are not, if I see a woman during her pregnancy, she will then go to any of the surrounding hospitals to have her baby, okay? So I don't have information on birth data or when she delivered. We really need a better network for our patients. Also, after an individual gives birth, they're often very disconnected from their health center, right? We say, come back and see us in 6 weeks. We encourage the parents to bring the newborn in for care, but often they feel very disconnected, alone, and isolated. And this is when, as you saw by that chart before, many women can have complications. And this is when, adverse events can happen and leading to maternal morbidity and mortality. So developing this database is the first step in terms of providing appropriate care management so that we can then have a warm handoff to our clinicians in family practice or in internal medicine, who will then go on to manage their hypertension and diabetes or the other problems that were identified during their pregnancy. But again, I'm in an under-resourced clinic. So we've got a little grant right now, and we're trying to figure out how to do this. But that bigger question that we looked at earlier, how do we make this sustainable, right? How do we change the standard of care so it's not just while we have the funding to do a project to see if it works, but how do we really rethink critically about what we're doing and the care that we're providing? So we've got a lot of work to do, and I'm so grateful to be on this team too. National service, so I've been pretty lucky. I'm working currently, I'm on the board of directors for my national organization, which is Nurse Practitioners in Women's Health. I've been elected to be secretary, which is kind of cool, so I'll get to stay on the board. Yay, I know, I'm so happy. I'll get to stay on the board for a couple more years, which is great. We've got a conference coming up virtually. I've got 3 presentations that I'm doing nationally, and that's really exciting. I'm also the co-chair of the academic program leaders, which means that I sit with all of the other directors of the Women's Health Nurse Practitioner programs across the nation, and we talk about what's going on. We talk about what our students' needs are. We talk about what resources are available. We're having a really big conference coming up about structural inequalities and structural racism and what's going on within our profession and how we can be better. So there's a lot of really great thinkers, and I'm so honored to be the co-chair of this committee. I'm also working on a national committee on the Women's Preventative Services Initiative. I'm on their dissemination committee. So the WPSI is really setting the standards for the preventative care that women need. And again, I'm really honored to be on that group. It's a big bunch of work, but it's a lot of fun. I'm currently working with the American College of Obstetricians and Gynecologists on a national committee looking at the clinical consensus data for their gynecologic work. And I've just presented at a conference on sex and gender and health, looking how sex is a biologic variable and gender is so important as we look at how we react and respond to the healthcare and the needs that we have. And I just did a presentation on how we can include this in education for our nurse practitioner students. So this felt very narcissistic, talking all about me, and I really want to thank you for your indulgence of letting me share what's going on with Sandi and where I'm at and what's motivating me. I would love to hear from you. I would love to know, how we can work together to solve some of the big problems that are going on. If you have good projects, if you want another team member, please know that I'm here. Like, I'm a resource. I'm not going anywhere. I am thrilled to be part of Loyola. I'm so glad I've made these connections at Curl, and I want to continue the good work. And I'm not going anywhere. So we've got some time for some questions. I see a couple things in the chat. Whew. That was a lot about me. That's a lot about Sandi. Okay. Oh, say hi to Arden from me. Good. So Christine, yeah, all the cool people know each other. I mean, I'm really starting to understand this. The longer I live in Chicago and become a citizen of this, of this great academic world, it's really nice to see the connections. Oh, and yay, my cat made an appearance. So Emily had her cat in earlier. Now Ben is here to cheer me on. So
I had a question though.
Yes.
So I had worked on this project actually in the 80s called 9 by 90.
Okay.
Which was supposed to reduce infant mortality in the state. And then I know that there was another iteration of that you referred to in terms, and you said all these different things, but one of the things that they did in 9 and 90, and I'm just wondering what you think of it, is try to create more paraprofessionals and more almost, quote, barefoot doctors concept in terms of, reaching people and doing home, doing neighborhood work in order to, and this was focusing on prenatal care, not postnatal. And also at that time, it was really clear, and it's been clear since then, that the concept of visiting nurses has fallen away. So I just want to know what you think about all of those strategies, and are they part of the mix and discussion now?
So Christine, I love you. So and working with Arden also, Arden has been around for a very long time, and she is adamant. Like, we know that the system is broken, right? We know that the way that we continuously are trying to provide care is not meeting the needs of the people that are out there, right? So we have known that there are models that have been shown through good studies on the importance of peer counselors, the importance of home health nurses, the importance of teams that deliver care in a different model than what we're currently doing. I mean, I firmly believe that our current model of having, visits from 8 until 4:30 in a community health center is not meeting the needs of our patients who are working or have to come across town on 3 buses with their 2 kids, and then if they're late 15 minutes for their appointment, they have to get rescheduled. Like, we know that this is broken, okay? So the fact that we keep doing it over and over again is not really genuine for the changes that we want to see happen. So and I feel like talking to you is the same when Arden's like, oh, we tried that, we did that, it worked, but there was no money for it. Nobody wanted to reinvent things, and nobody wanted to invest in a different care model. Okay, we know the benefits of centering pregnancy. We know group prenatal care, group parenting care. We know peer counselors help with breastfeeding. Like, there's data to support this, and yet the funding isn't there. So part of the work that we need to do as we look at the infrastructure moving forward is we need these creative ideas and innovators and folks who know where the evidence is in terms of trying to rethink how we're delivering care, right? So the Affordable Care Act is a step in the right direction in terms of everybody having health insurance, well, most everybody having health insurance, but we really, really need to rethink, how we're doing things. Arden's actually working on a study right now that is looking at bundling postpartum care and newborn care. We know that parents will bring their newborns in for well child checks. I know from experience that as a new mom, like, you're very invested in making sure that your newborn is okay. However, many of the women who've given birth, or many of the people who've given birth, don't set themselves as a priority. So they don't come back in for their own postpartum care. They're not getting their blood pressure checked. They're not getting their depression screening. They're not getting their blood sugar checked. They're not, we're not knowing if they're anemic. We're not anticipating any other outcome or problems. However, if we could bundle this care, you know, one-stop shopping, like go ahead and check her blood pressure when she's over in pediatrics, go ahead and give her the depression screening. It makes so much sense. And yet, you know, I'm fortunate that they've got a study that says, hey, we should do this, but it seems kind of intuitive to me. So let's hope that that study is robust enough for us to be able to change the way that care is provided, or else again, it's going to go, I mean, we know that there's a lag between the research that's done and the actual implementation of this research at the clinic level area, right? And that's one of the things that I think that the doctorate of nursing practice is really starting to respond to, because we're really trying to use this next generation of advanced practice nurses prepared at the doctoral level to be able to do these clinical effectiveness trials, to be able to say, hey, here's the best evidence. I know that when you did your randomized control trial, you had to have a very homogeneous patient population. And you know, now we know that this is messy. In an actual clinical setting, it's messy. You're not going to be able to exclude people because they don't meet your inclusion criteria, right? So how do we then get the best evidence to actually be embraced by the stakeholders, supported by the finances, incorporated into a clinic, and evaluate what the outcomes are on that? I see a great question on how can non-healthcare workers, or what can non-healthcare workers do to help? We need all hands on deck. Okay, so you know, God bless my clinic, they want me to see patients, okay? So they don't want me to be sitting back and looking at their data and trying to figure out how to do things. They want me to see more bodies. They want, you know, I'm seeing patients every 15 minutes and it's making my head spin. But I'm fortunate because I have this opportunity as an academic and as an educator to step back and look at things a little more critically and figure out what we can do differently. Most of our healthcare professionals can't do that. We need all hands on deck. We need the folks at Curl. We need the folks in social work. We need the folks who are, you know, peer educators. We need the community health workers who are on the front line. We need everybody to come together and say, hey, you know, if you are not getting the healthcare outcomes that you want, and again, healthcare is not just her hemoglobin A1C, okay? I'm looking at those social determinants. I want to go more upstream. I want to figure out what we can do to reduce trauma. I want to look at what we can do to get her as healthy, or get the individual as healthy as they can be before they get pregnant, so we can have a better birth outcome, right? We need everybody to do that, not just the folks that are putting the speculum inside the vagina, right? That's what I have to do every 15 minutes. But we need you. We need everybody. Good questions. And I would love to be part of a team. If you've got a project, I've got a lot of enthusiasm. I'm a great cheerleader. I'm a great team member. I am happy that Loyola allows us to work across campuses. We are challenged geographically at Loyola, right? We're not all sitting at lunch together. Definitely not now during COVID, but it's really hard to get from Maywood to Lakeshore and to Water Tower. So any opportunities that we have that we can come together and have forums like this, where we can bounce around ideas and say, hey, you know, how do you want to change the world? How can I help you, right? You know, and it helps us, you know, as a community to recognize that we are not in this all by ourselves, right? You're not alone. I'm not going to solve all these problems by myself. I need those angels on my shoulder who are going to encourage me and motivate me and push me and pull me and pull, you know, get me on their team so that I can be part of the solution and not part of the problem.
Sandi, I'm just curious whether you have done any sort of cross-teaching with, say, social work, or trying within Loyola educational program, or social work in women and gender studies, and I know you've probably got a full load, but I'm just kind of curious whether there's opportunities for that kind of education. I thought about pulling the pin on the hand grenade and staff, talking about whether introduce some of this at a introductory level in the core curriculum, but I know that will somewhere, whoever's in charge of core these days is silently being that I'm talking about adding to the core. But it just seems to me that trying earlier on in the educational process within Loyola, just starting in that universe and university, just trying to think about how we do cross-disciplinary education opportunities, because it was certainly not a part of my liberal arts education.
Oh, David, thank you so much for that question. And I'm laughing because Susan Bushell is on this with me, and she's my associate dean for the graduate programs. So One of my biggest challenges is that I say yes all the time. Like, I would love to do that. I would love to do that. And I think that, the idea is so exciting to me to offer this cross-disciplinary work, to have these conversations where we come together with our lens through social work or through sociology or through anthropology or through, engineering. I mean, like, there's so many different aspects to what's going on, and we need, like I said, we need all hands on deck. I have really, one of my biggest challenges, again, is trying to minimize what's on my plate so that I can focus on the stuff that I'm supposed to be doing. So a little known story is that we were asked to reapply to be the directors of our program. We had a new dean who said, if you want to be the director of your program, you need to reapply. And I had to think long and hard about it because I am overextended. I'm overextended in my teaching role. I'm overextended in the amount of work that I have to do as an academic related to the service committees that I'm on and the work of being the academic advisor. And I take on way too much stuff, plus I'm seeing patients and I'm doing research and I'm teaching and I'm directing a program and I'm doing all this national service and I like to go dancing, so how do I do it all? And I felt for a moment that might be something that I had to give up, that I had to step back from. I had done it for 10 years. I did a really good job. I have a 100% pass rate for my students on their national exams. Like, we're doing something right at Loyola, and I take some credit for that. But I was able to work with my administrative team and look at my obligations and ask those who wanted me to remain in this role to help protect me. Because I'm sometimes my own worst enemy. I'd be like, yeah, I want to guest lecture for you. Yes, I want to co-teach this class. Yes, I want to be over and, I want to come hang out with you guys because you're doing new fun and exciting things. So while I hope that while I'm at Loyola that I can do this, I think part of where I get the charge out of this is also at national conferences where it's really interprofessional, I would love to, I know that we have something like teaching, the focus on teaching and learning where we're learning best practices in Ignatian pedagogy for education, but I would love to see some kind of, a conference through Loyola where we all come together. And I'd be happy to participate or communicate or do something with that. I think committing to a course, I'm more than happy to guest lecture. I see Pamela Pearson's on here. She's one of the faculty at the University of Illinois at Chicago. I just spoke to her midwifery and women's health students on Wednesday on sexual dysfunction for women. So I'm more than happy to guest lecture. Like, I think that's awesome. Hey, Pamela, thanks for showing up for me. So I'm more than happy to guest lecture because I do think we need new voices. I mean, I think we need to hear what's going on across the campuses. I think I'm so much smarter when I hear what you all are doing, right? So when we're able to collaborate together and see what projects you're on, and I think, oh my gosh, this is a great community-based organization that I need to figure out how to be part of this project, right? I'm so grateful that that you asked me here today, and that I hope that we can find a way to continue to work together. But yeah, I'd love to have a joint appointment in women and gender studies. Like, I'd love to have a joint appointment in the College of Medicine. Like, like we've got a lot of work to do, and we should, because
one thought, sorry to interrupt, one thought that does come to mind is perhaps not thinking about a whole course, a semester long course, but a weekend workshop, which sociology, we can tell you about that later, but sociology used to kind of operate something like that. Something that's I won't say bite-sized exactly, because I know a lot of work goes into it. Weekends kind of, a lot of work goes into that, perhaps as much as a whole semester's worth in some cases. But thinking about it like in little bits and pieces, and seeing what the response is too, right? What are people interested in? What are students interested in? So.
Yeah, I think that's a great idea. I think often we, as an academic, I'm encouraged to disseminate my research, right? So I go to national conferences and talk about what I'm doing. And as a clinician, I'm being asked to talk about best clinical practices at national conferences. So I would love to have this interdisciplinary approach right here at Loyola, where we come together and we say, what are you doing about this? And the health sciences campus has done quite a bit of this on health equity over the last few years, which has been pretty great. excuse me, but I feel like we are somewhat geographically isolated. And that might make it a little bit more challenging for students and faculty from other campuses to come together. So we have to think creatively about this, and maybe in this time of COVID where we're getting together on Zoom, like we could do this, and that might be something to think about now that we know that this technology is not as cumbersome as we once thought it was. We're doing national conferences where we're recording ourselves and coming together in breakout groups, and all of the great work that Loyola has done on institutional racism over the summer. I participated in a lot of those workshops and book clubs, and I'm watching the movies right now. And so, I mean, I think that there's a lot of opportunity for us to, to continue to figure out how much stronger we are together to solve some of these problems, or to at least look more critically at these problems and figure out how we can be, working towards the solutions. But thank you. And yeah, if you hit me up for a guest lecture, I could, if Susan lets me, I can do it.
I've already suggested to the person who's teaching the Urban Studies seminar, which is the capstone courses for the Urban Studies minor, that perhaps if she's got it in her docket for next semester or the semester after, maybe we should reach out to you. So no threat implied in that. Spreading the word.
Thanks, and thanks for that. I mean, that is a true testimony to the fact that that the work that I'm doing is worth repeating and worth getting the word out there. So I really appreciate that. And Christine, can we resubmit our grant? Can we do this? That's some big work. I thought it was great. That always happens when there's so little funding and it's so competitive, and when you don't get funded, it's a little bit soul crushing. And as an academic, it's important for us to, like, all you got to do is revise and resubmit. We just got to revise and resubmit. We can do this. Because like I said, unfortunately, trauma isn't going away, and homelessness is not going away, and the needs of these individuals and the frontline workers in healthcare and community service, they're not going away. We just need the money. We need some money. Oh, well, I want to thank everybody for spending some time with me this morning. I am so delighted that you carved out some time in your day to hear about me, and again, indulging my closet narcissism to come out and talk about the good stuff that I'm doing. I'm delighted to be a part of this Loyola community, and I'm so glad that I've made the connections that curl. And I feel very honored that I've been invited to present today. So thank you from the bottom of my heart.